All right, guys. I think we should just start the event and people can join in as we move on. Um, Dr. Omoleye.
Okay, I'll open my video and share my screen.
Yeah.
Shortly. Can you see a full screen with
Yeah.
the slide title?
Yes. Yes.
Okay. All right. Turn on my video. Okay. Hi everyone. My name is Subomi. It's nice to be here. First, I want to thank my friend Moti, Dr. Tengu, for inviting me to speak. I really love to share experiences and tips because um, that's what helped me and has helped others along the line to apply to radiology. So, to introduce myself, so you know my name. I'm an incoming radiology resident at the University of Chicago, and I'm also going to be doing my prelim. So, 1 second, because my pointer is not showing. I'm going to be doing my prelim year also at the same hospital. I'll explain what that means for those that don't know what a prelim year entails. So the objectives I was given were to talk about, the basic structure and requirements for the US radiology training pathway, and I'm going to be sharing about the application process for matching into radiology. Try to get a sense of what factors improve a candidate's chances for successful match, and I'll also talk about the typical day-to-day responsibilities and expectations of a radiology trainee. Even as someone who is, still about to start radiology proper, there's some insights that I am able to share on that, and and just share personal experiences and tips. So I want it to be interactive. I know that the video is going to be saved, put on YouTube for people to refer to later, but please feel free to put questions in the chat. And the slides will just serve as a guide and not, I'm not here to cogitate information that you can easily find online. I want it to be as helpful and as interactive as possible. So at the end of the session, if there are any questions you have or that you had coming into this that you feel that we can talk about, please feel free to ask. So to talk about radiology, and I'm keeping the black and white theme as part of the culture. Radiology in the US, the residency training for radiology is 5 years. That's for diagnostic radiology. There's also integrated interventional radiology track that is 6 years. So when you think about the duration of radiology, always keep in mind that the first year is the internship year. It's also called, some people will call it a transitional year, depending on how the first year is structured, or a preliminary year. I am doing my preliminary year in internal medicine. Some choose to do theirs in surgery. Some even choose to do in obstetrics and gynecology, pediatrics, depending on what you want out of your first year internship. Radiology does have requirements on what that first year should entail. So typically people will go with internedicine or surgery, and then the remaining 4 years, we call it R1 to R4. So R like radiology resident 1, and R1 will be a PGY2. So PGY means postgraduate year, if you've heard or seen that somewhere. And your postgraduate year 1 is actually your intern year, and your R1 starts at your postgraduate year 2. While the interventional radiology is 6 years. And same concept with the preliminary year. People who are going for interventional radiology would usually choose to do general surgery for their first year, just because IR is more procedure oriented. And then R1 to R5 would be the interventional radiology proper years. And then, so just there are many fellowship opportunities in radiology. and just talk a bit about what the curriculum looks like. So, like I said, the first year is the intern year. You're not really doing radiology in the first year. And then you have R1 to R4. This is a diagnostic radiology curriculum. So if you look at the spread, you're really looking at different body parts and looking at different modalities. So with the first year, the first year is more of going to be two-dimensional imaging, some three-dimensional imaging with CT. Most programs don't do MRIs the first year. I think that's the second year for most programs. But the general thing, the general concept is that the first year and moving up onto the fourth year, there's graded responsibility and graded autonomy in doing the reads and whatnot. And diagnostic radiology residents also get interventional radiology rotations because even diagnostic radiology involves procedures. So one myth is that diagnostic radiologists don't do procedures. That's not true because diagnostic radiologists, depending on what subspecialty you pick, you can be doing a lot of procedures or you could really not do procedures. It really just depends on how you want to shape your practice. But there are many opportunities to do procedures in diagnostic radiology. For interventional radiology, so the training for IR is pretty much identical to diagnostic radiology up until PGY4, also known as R3. And then from R4, so, here, this R3, this is where radiology will end at PGY5. So for IR, for people who match into the integrated IR track, this is the year that they start to do more IR. And then there's one more year of just IR, also called like an IR fellowship. There is a track that I don't up here because it's part of, it's an opportunity for diagnostic radiology, people that match into diagnostic radiology to specialize in IR. Basically, it also looks like this. It's called ESIR, early specialization in IR, where usually in the R2 year, radiology residents, diagnostic radiology residents who are, find out that they are interested in IR can apply for that pathway. And then when they get to their PGY5, instead of doing mostly diagnostic radiology, they will do mostly IR. And then they will have to look for a 1-year IR fellowship that may or may not be part of the program they are on. So the integrated IR is called integrated because that extra 1 year of IR fellowship is part of a program. So you know that when you match into an integrated IR, you're going to complete all your DR and IR training in the same place. Whereas if you match into DR and you change your mind along the line that you want to do IR, you apply for the ESIR pathway, and then your track now looks like this, where you do IR in the R4 year, also PGY5, and then you look for a 1-year fellowship that may or may not be part of the program that you are in. So the daily schedule for DR and IR residents is pretty much the same for the first 4 years. I said earlier, and the daily schedule is by program, but as the curriculum I put earlier is just an example. This is for UChicago, and the earlier DR curriculum was for Yale. But most programs have similar curricula. It varies by program. Some programs start at 8 o'clock, some at 7:30, and then some programs will start with like a morning conference. Others just go straight into work, and then what you do as a resident really is you read studies, and then you read out with the attendings, and then you addend the attendings changes, and then you basically, once you add what the attending has said, then you finalize the report. Usually most programs have a midday conference around lunchtime where you grab your lunch and then you go for noon conference where people present on different topics, and then you go back to work, and the same thing, interpret studies, read out with attendings, and then addend reports, and then most programs would end at 5 p.m. like typical work day. So that's kind of how the schedule looks like for DR. IR obviously would be more proceed during the day and whatnot, but that's more DR. So to the match. So I'm sure most people on this call have heard of the match. That's kind of some people's first introduction into US residency. And there are some names that you need to know about the match. Everyone knows that the match happens in March. It is organized by the NRMP, as National Resident Matching Program. The ECFMG, so it's good to know like what each of these stand for and how we fit into each of these. You can think of ECFMG as the dean for international medical graduates. So American medical graduates, also called MD seniors, when you look at publications from the NRMP, those the medical graduates from schools here are in schools that are accredited by the nation. So there's kind of a trust system, an accreditation system whereby these schools can send forth their products to residency training programs, and no one needs to certify the candidates coming from those schools because there's already a liaison committee for medical education, LCME, that governs basically medical school accreditation. To match into a program, you need to be certified by the ECFMG. So the ECFMG is now what stands in as the dean of IMGs. What the medical schools in the US do for their students and eventually graduates to match. That's what ECFMG does for us IMGs. That's why it's called the Educational Commission for Foreign Medical Graduates. Now, not all medical schools, not all international medical schools, I'll rephrase that. Not all graduates, depending on the school that you're coming from, can be ECFMG certified because not all medical schools are recognized by ECFMG. So if your medical school is recognized by ECFMG, then you can start the process towards ECFMG certification, which I'll talk about. Now, the NRMP we've talked about, that's the body that organizes the match between candidates and programs. And that's where you submit your list, what they call the rank list, to. Now, that's the electronic residency application system. Is owned by the AAMC, Association of American Medical College. And ERAS is the, basically you can see ERAS as the body that helps you manage applying to the different programs. So it makes sense because this is the Association of American Medical Colleges. You're going into ERAS, you create an account with ERAS, and through ERAS, you can access applying to different programs. But when you apply, NRMP is what now organizes the eventual match when you've applied and interviewed, right? So you understand more, but I just want, for those that don't know what those mean, those acronyms mean, kind of like an introduction to that. So NRMP, to participate in the match, basically, that's NRMP eligibility, you need to have a medical degree, obviously, if you're not a US medical student. And while you don't need to have ECFMG certification at the time that you are registering, you need to have met the requirements for ECFMG certification by the time that the rank order list is due. That's usually around February. I'll need to check the timeline, but the NRMP releases the timeline every year. So the safest thing is to meet all the requirements for ECFMG certification before you sending applications. That's the safest thing to do. So you don't need to be physically present in the US to participate in the match. Right? So this is the match process that's published on the NRMP's website, so you can go look it up. So people apply for training, and then You register with the NRMP, and you interview with programs. So after you send in applications to areas, programs call you for interviews, you interview, and then you rank programs rank you, NRMP runs the algorithm, and then the match results come out. So that's kind of like a snapshot of the match process. So to obtain ECFMG certification, which you need to match into a program, this is a given. Graduated from medical school, but the exams that you take are the USMLE Step 1 and Step CK. USMLE means US Medical Licensing Exams, for those who don't know. There used to be a USMLE Step 2 CS. So CK means clinical knowledge and CS means clinical skills. CS was cancelled during COVID and it's not coming back. What has taken the place of CS is the OET, Occupational English Test, that tests your ability to communicate in a clinical setting. CS used to involve patient encounters where there'll be a preceptor that was you take history, examine, etc. And that examine those skills, also your English skills indirectly. But now that has been taken over by OET. So you need to satisfy requirements to be ECFMG certified. And there are different pathways for ECF certification. You can read more about that here. But this is the common pathway. Passing the USMLE steps, passing the OET, and then applying for ECFMG certification. The pathways will also depend, the pathway you choose will also depend on if you are licensed to practice anywhere else in the world. But go through this link and you see all the different pathways for ECFMG certification. So for the USMLE exams, that's really important to talk about because, again, the data has shown that the STEP exam performance is the single most important predictor of a successful match. It used to be step 1 when it was scored, but now step 1 is pass or fail. And I think that the recently concluded match is the one that, period where step became pass or fail, but some people who were applying for the match were people that had scores. Those usually were international medical graduates. So residency admissions committees had to look at candidates with scores and candidates without scores. For example, I did my step 1 in 2021. So I applied for the match last year. I had a score and there were co-applicants who didn't have scores. But I think this year, there will still be applicants who have scores every year, depending on when they wrote step 1. There are probably people who wrote step 1 many years ago who will be applying for the match now. But by and large, that percentage is going to keep reducing. And then there'll be a point where virtually no one has a step 1 score and then it becomes totally irrelevant. But if you have a step 1 score, know that it will be looked at because the USMLE sends your transcript. It's not going to blur out your score as pass just because others have pass or fail. If you score, it will be in your transcript and programs will see it and potentially factor it into their decisions because they can see it. So one is 1 day, it's a 1-day exam, it's 8 hours long, and it looks at the basic concepts, basic sciences that are relevant for medical practice. So think anatomy, biochemistry, physiology, pharmacology, and also behavioral sciences, mostly psychology, and then you have some biostatistics as well. So you can know more about the curriculum, just go to the USMLE website, look at what the curriculum is. There's a standardized curriculum, and there is a set percentage of questions that have to cover each of the domains that they are testing. Now, study resource will ask this a lot. I just think UFAP, that's like the key. I think that has, everyone says UFAP because it just works. So UWorld, First Aid, Patoma, acronym. UWorld has just over time shown themselves to be, they've been around for a long time. They have lots of people working on them, gathering the USMLE tests, curriculum, and getting information on what the questions are like. So the UWorld will probably be what, be the resource that will give you like a closest representation of the step 1 exam. Other helpful resources, Kaplan Medical, sketchy videos, Architects. I used all of these resources that I have put up here So they help, that I can say. And I think that the way that you study will also depend on you, like your study style. There's no set advice on how long should I study for step one, because when step one used to be scored, people would say study for 6 months. So people would say study for 3 to 6 months. But to be honest, there's really no set amount of time. The time you need is the time that you would need to get to the score you want. So if you just want a 240, and now it's not pass or fail. But again, if you just want to pass, then there's a time you need to study. If you want to pass and understand the concepts that will help you for step two, then there's also, you have to factor that into your decision on how you want to prepare. Step two is now the new benchmark. So step two is more application focused. It's more clinically oriented. I'm not going to see questions like what is the enzyme, what's the rate limiting step in this pathway, what stain are you going to, you're not going, probably not going to see those types of questions. You're going to be seeing questions around what's the next best step in this patient, what test would you order, what's, usually what's the next best step, what test would you order. Those tend to be more common questions. And then you will see drug posters where you have to interpret data from like drug pharma posters and whatnot. So it's a 1 day 9 hour long exam. The main resource for this, people will tell you, is UWorld, and I agree. You can also supplement with AMBOSS and first aid. But personally, UWorld was my primary resource, and AMBOSS I supplemented with AMBOSS. So studying for step two, the resources are a bit more trimmed, but it's not a walk in the park. You definitely need time to study for the exam, and again, the amount of time you devote into studying would also depend on what your target is. And I presume that everyone here wants to apply to radiology. So if you're thinking of applying to radiology, you want to beat the average performance of typical applicants into the program, especially as an IMG. So that kind of helps you think about what you should target for the exam. So here is data released by the NRMP for the 2022 match. So if you look at, I only picked out the one for IMGs because that's what's relevant for us. If you look at diagnostic radiology, the blue bars represent the matched candidates, and the green represent not matched. You can see that the average score for matched candidates into diagnostic radiology for US IMGs was somewhere just slightly less than 250, and for non-match was slightly less than 240. For the non-US IMGs, you can see that the average step two CK score was over 250, slightly over 250, and the unmatched was slightly under 250. So that was like a very close margin. You can see that the non-US IMGs have a higher step two CK score than the US IMG. So it kind of tells you, what competition you're up against and what to target. So someone would tell you that for radiology, you aim to get 860 and above for step two. That's like a safe score to have. When step one was still there, the advice would be to aim to get 850 and above. So just so that you are comfortably above the mean score, because number one is competitive, and number two, you're an IMG, so you need to beat the average. If you look at, and this person on Twitter, JB Kamondia, you may want to follow him if you want to follow statistics on the match. He posts really helpful infographics and summarize the match statistics and whatnot every year. So definitely follow him. He did not ask me to advertise his handle, but I find he was really helpful. You can see here that the step one pass rate has dropped, particularly since it became pass or fail. It's still high, it's still above 9%, but it's definitely dropped. But the takeaway there is that for radiology, if you look at the applicants or the people who are in programs already, just 0.4% of residents in radiology ever failed any of the steps. So for step one, as someone who is, if you're thinking of writing step one, then aim to pass, because you don't want to be in that small percentage that, let's just say that there are not many people who match into radiology who ever failed any of the steps. So if you want to optimize your chances of applying, then aim not to fail step one, because apparently failure rates in step one have risen since it became pass or fail. If you look at the spread of candidates, so you can think of this as like from increasingly competitive to less competitive just by how many MD. So MD here means like US medical graduates. DO means doctor of osteopathy, also typically from the US. Then IMGs here includes both US IMGs and non-US IMGs. The yellow means on field. So on field means that after the match, there were still slots available. If you look at radiology here, I think this year there was one on field spot after the match. Last year there was none, and a small percentage of the people who matched into radiology are IMGs. So it's really the summary. The takeaway is radiology is competitive. It's becoming more and more competitive. So that's to kind of orient you into how to think about preparing your application in a way that reflects that how competitive radiology is. And you also look at the mean number of applications per applicant. So the average applicants into radiology applied to around 73.5 programs. So that's just to also a measure of thinking, how competitive is this program that I'm applying to. So there's something called preference signaling that's in recently that I want to explain, because I think people get confused about signals. So when you apply to any specialty, be it, when you apply to the match, you can apply to more than one specialty. For every specialty that you apply to, you have a limited number of signals. For diagnostic and interventional radiology, you have 12. So you won't have 12 signals for IR and 12 for DR. So if you're applying to radiology, you have to spread your 12 signals across both IR and DR. And the reason you see this yellow is because there are 6 gold signals and 6 silver signals. And the programs will know if you signal them. A signal is, like here, you saw that average applicants applied to over 70 programs. Those say I applied to 75. I applied to 90. Yeah, I applied to 90 programs. You have to apply to as many as possible to optimize your chances at getting interviews. You have 12 signals. So the gold signals and silver signals are ways for programs to know like how much does this applicant want to come into it, because they are limited. They're 12. So for you to give one signal, if a program sees a gold signal, then that program knows that they are in your top 6 choice out of all the possible programs that you could have applied to. They're in your top 6. And the silver signals will tell the programs that they're in your top 12. But it also tell them they are not in your top 6. Theoretically, they shouldn't think that, because you could choose not to use your signals. You could choose not to use any of your gold signals and use only silver signals, in which case a program that's silver signaled will be in your top 6, but most people know that you use all your signals. So if a program sees a silver signal, they know that they are not in your top 6, but at least they're in your top 12. I heard rumors last year that programs were not even counting the silver signals because of how competitive radiology is. Especially really competitive programs, like think of applying to like Johns Hopkins and then they see a silver signal. Why are we not in your top 6? That's the question they're going to be asking themselves. So people advise to use your signals wisely. So apply, yes, definitely allot signals to really competitive programs that you really want to get into, because if you don't, you're probably killing chances at even getting an interview. Because um, I heard rumors, again, for people that knew program directors, that um, signals were used to filter candidates. So, um, say an interview had like 100 slots for interviewees. So every program has a limited interview quota. Most programs had, depending on the number of residency slots that the program has, um, then that would determine what the quota is. So a program that has about 10 slots might have 10 residency slots, might have 100 interview slots. So a 10-to-1 ratio. While a program that has just two slots will only have 20 interview slots. That should also inform how you apply. If you're really limited on resources, as an IMG, you probably want to apply to bigger programs because you have a higher chance at being interviewed at those programs because they are bigger. So they offer more interviews. And not surprising, many programs start out by first considering US medical graduates and then IMGs. If you're a really competitive IMG, you can scale through some of those filters because they are there. And they are there. Let's just put it that way. So for really competitive programs that you really, really want to get into, I would say definitely signal them. And then also include like programs that you have an edge that may not be as competitive. So when I say an edge, maybe you did a rotation there, or you know someone there, or you did some research there, you already have an edge. So if you don't signal them, you're kind of telling them that I don't really like you, even though I know I have an edge. I don't really, I don't like you enough to give you one of my top 12 slots. And so that might just kill your chances. So if it depends on how, again, all of these things should be based on how competitive we think you are. There are candidates who I heard from program directors that at the RSNA conference that, there were program directors that interviewed candidates that did not signal them. And these were program directors that really top programs based on the merit of that candidate. So say the candidate is just so good, they can still offer an interview to a candidate that did not signal them. The way that the NRMP, the NRMP or ERES, the way that they told programs to use the signals is it's supposed to be used as a tiebreaker. So if there were two equally qualified candidates, the signal can be a tiebreaker. But everyone goes with the path of least resistance, so it's easier to just use that the filter because most people at radiology are very qualified. It's hard to say when two candidates are equally qualified to even start to think of a type. Step 3 is you don't need to do step 3 to be CFMG certified. I matched without step 3. This is solely based on, again, how you look at your application. If your application is not so strong and you want to give yourself just another edge, then maybe writing step 3 would help. For radiology, I don't know how much it helps because radiology starts at year 2, remember? So by the time people are coming into year 2, they've already written step 3, right? As IMG. So radiology program admission committees probably don't look at passing a step 3 as important. But if you just want to give like every little bump counts for competitive specialties. So that might just be the thing that makes you more qualified than someone else. So if you can write it, but people match without step 3 all the time. IMGs, if you have great step 2 scores, it becomes less important, but it might give you an edge. So the other thing I did mention about the steps is that the sequence, you don't need to take step 1 before step 2. You could take step 2 before step 1. And this is important because there are people who really want to apply this year. You could potentially take step 2 first because you know that that's the one with the score, and then take step 1. But again, just the message is there's no set sequence. You can do step 2 and then step 1. So for the 2025 match, the ERAS season begins June 5, so less than a month away. ERAS season begins. Basically, what that means is you can create an account with ERAS and you can start putting your application together. So getting your personal statement, getting your letter of recommendation, etc. You can start working on those now, like as early as June. And then in September 4, you can start submitting to programs. Programs will not be able to look at the applications until September 25. So that gives you like an idea of a timeline. So it means that if you're going to get letters, we want all your letters to be submitted before, give it a week before, because letters take time to, it's not like once the letter writer submits that it will be available on ERAS. So you want to see, look on ERAS, they will tell you how many business days it takes to process a letter. Give yourself enough time. I can't stress that enough. You need to give yourself enough time so that you don't feel like you're rushing your application. Your personal statement, you can start now, because it takes time to write a good personal statement. Letter writers, that's like the rate limiting step for most people, because you can write your personal statement overnight. It'll be a good personal statement, but at least you'll have a personal statement overnight if you choose to. It might even be good. But it's probably not going to be good if you rush it and submit. But your letter writers, you can't rush them. You can't send a request for a letter today and say that you want it tomorrow and expect them to write a good letter for you. So those are the things that you need to work on early. CV, you can prepare your CV in one day. You can't prepare the content of the CV in one day. So the research, the CV entails like research, etc. So if you're thinking of publications, remember that by those publications should be out by the time that programs can access your application. They should be on your CV. So the ERAS application has fields for awards. They have fields for research, and the research has subfields. So there's fields for research that has been published, research that has not been published, conference presentations. So all of those things count, especially for programs like radiology. So I gave like a brief overview of the NRMP earlier. Ranking programs. So when you apply and you get interviewed, then you rank programs, and then programs rank you. Ranking programs also should depend on, like, you should reflect on how your interview went, and you should really think about what programs you want to go to, because always remember that the rank favors the applicant. When you're applying and when you're making a rank list, just keep in mind that you should rank the program that you want to go into the most first. Just take it like that. If you try to game the system, then you may not get what you want. If you rank the programs that you like first, the algorithm helps to see if they can match you into that program. And if they can't, they'll go into your number 2. So it favors you as the applicant. SOAP is relevant when they are on field sports, but for competitive specialties like radiology, there tends not to be sports in the SOAP. So I won't really rely on the SOAP. I talked briefly about what you need to participate in the match earlier. USMLE letters, applying to programs, and ECFU certification. So people don't really think of this when they start to apply, but you should think about visa and immigration. So you don't need to be in the US at the time you're applying. Programs would typically be able to sponsor a J visa. That's an exchange visa. Programs can sponsor a H1B, not all. So when you're applying to programs on ERAS, you want to, if you're not a citizen or permanent resident, you want to look at what the visa sponsorship for that program looks like. You can look at it on ERAS or Residency Explorer. You cannot look at it now, unfortunately, if you don't have an ERAS account. But once you once you open an ARS account in June, you can start to look at all that information and then use that to decide how to rank programs depending on what you want your visa situation to be. Yeah, that's about visas. And then I put some like FAQ I get, and I will just talk briefly about some of these areas. You should start preparing your application yesterday. Like the moment you realize that you want to apply to radiology, that's when you should prepare your application, because applications are long and tedious, and you want to think about what will make me a competitive applicant, and then start to do all those things. How many programs should I apply to also depends on it depends on how competitive you are. So if you have high step scores, you have research, you have a network, you can tailor your application a bit. And if you also know what kind of practice you want, so if you really know that you want to be in an academic radiology program, then you should probably not apply to community programs, because even if they interview you, unless you're really lacking for interviews, you're probably not going to rank those programs. So you could go the safe route and apply wide just so that you can get as many interviews as possible. People advise that because it's better for you to have options than for you to be constricted. But if you're also balancing that with finance, then you should really think about what kind of programs I want to get into, and then use that weighing your competitiveness to decide how many programs to apply to. But probably don't apply less than the mean. So last year, people on average apply to over 70 programs. So you probably want to do higher than that. Should I apply to backup programs? That depends on how competitive you are. So if your scores are low, but you really want radiology, you can still get in, but you have to now buttress the other parts. Have research, have networks, have things that are interesting in your portfolio that the residency admissions committee can look at and say, oh yeah, this is nice. Maybe have US clinical experience. But again, having a backup makes sense if you feel like you're falling short on some of the already public statistics about what successful applicants to radiology look like. And so the backup programs will be the less competitive programs that you can also see yourself in. The other thing to know about backup programs is that your preliminary or transitional year can, quote unquote, be a fallback. So if you feel like your application for radiology isn't so strong, you can actually apply to prelim or transitional year programs. Before the end of your prelim or transitional year program, apply to radiology again. I've seen people who didn't match the first time, who even had good step scores, and then had so many interviews by the time they were already in a prelim program. So that's something to think about. How can you seek out mentorship and advocate for the match? Everywhere. So Twitter has people who tweet stuff about mentorship, conferences, program websites. You could see the residents, the list of residents. If you see anyone that connects with you, or maybe, oh, that's a Nigerian, or that person went to so and so conference that I was also at, or this person does research that I'm interested in. Don't be shy, send an email, connect. Some of the people that were strong advocates for me in the match were people I met. There was someone I met through Instagram that helped me talk to their program director. So you can find advocates anywhere. Just look for what connects you with people. And that's where hobbies come in, because when programs are interviewing you, they're also looking at how would you fit into their culture. Are you someone that they can have an interesting conversation with? So your hobbies are not irrelevant. Your hobbies are really relevant, and sometimes those are ways for you to connect with people and advocate for the match. Your strongest advocates may not always be the people you've worked for the longest with. Some people are they just really want to help. So even if you've had a short interaction with them, like one of the letters I got was from someone I did a clinical rotation with as a medical student for 1 month. And at my interviews, people would keep talking about that letter. Oh my God, that letter was so good. And this was someone I only worked with for 1 month. So don't discount brief experience. Sometimes brief experiences are good because you can be on your A game for 1 month and really impress someone and get a great letter. How should I select LOR writers? For radiology, you want to have at least one letter writer that is a radiologist, because it doesn't make sense for your letters to be from internal medicine if you're applying to radiology. That's just one easy way for your application to be put aside, because you had a year or more to think about your application. And if you couldn't try to get one radiologist in your application, it means you're not really strategic, and then that could be a reason for people to just exclude your letter or your application rather. If you're applying to diagnostic radiology, a letter from an IR physician counts, because IR physicians are also, they do diagnostic radiology training identically up to a point where they split out. So a letter from an IR physician will be well received by a DR reader. And the reverse goes. You don't always need an IR letter for IR, but it's recommended for you to have. If you don't have, at least the bare minimum is to have a letter from radiology. Additional degrees and research. People talk about, should I come for a master's, and how does that help? The additional degree, the extent that you can tie it into your story. I initially wanted to do the master's degree, and then I got a postdoc research position, and then I was able to get research. I honestly think that people look at these things differently. Some programs value that, some don't. But by and large, I think what is the most important is how can you express how that additional degree makes you a better radiologist or radiology applicant? If you can't, then it doesn't really work in your favor. If you can, then it helps. But extra is always better. So someone with 2 degrees always looks more qualified than someone with 1 degree. But then when they dig into the application, people want to know, what did you do with that extra degree? How does that tie into your story, into being a radiologist? It doesn't have to be. You could come with an MPH and say that you are interested in global radiology, or the relevance of radiology to like public health with screening and whatnot. You could come with an MSc in data science and say that you're interested in imaging informatics. You could come with just research, and then your research portfolio speaks for you and for why you're interested in radiology. But everything has to make sense and has to tie into your story as an applicant. Preparing for interview starts now. So learning how to communicate with people, thinking about your story over and over again, just thinking about a personal statement and thinking about your CV. You should try to start practicing how you will express when they say, why radiology? When people get on calls with me about strategizing for radiology applications, because I've got a number of that since March, I always ask, like, why radiology? Because that's a question that will recur in your personal statement. It will recur in the interview process as well. So you need to keep thinking about that. Letter of interest, very important. So it's important for programs that you're really interested in, to start to try to interact with the program, maybe by an email to the program director before match season, saying, I like your program, I'm planning to apply, open houses. So programs have open house information sessions. Ask questions in those sessions. Let the program directors see you, so that when they look at the application, the name looks kind of familiar, or maybe the face they can still remember. Because the real bottleneck is that for IMGs, we look like, it's just a piece of paper. Someone's application's on a piece of paper, someone from some part of the world that you don't even know. You look so distant when they cannot connect to you. And one way for you to bridge that is to be visible to the programs by connecting with them, attending sessions, etc. Elective rotations always help. there's a point where there are diminishing returns where like you don't need to do a year, you can do a couple months. For radiology, you won't really be doing a lot of hands-on. It will be more watching for diagnostic radiology. Even with interventional, it's hard to get hands-on. So, but electives help. So if you can get it, definitely, and also try to get a letter from the elective. I talked about signaling earlier, and then people sometimes don't understand that in applying for radiology, you're applying to start at 2, you need to apply to a PG at 1 program. So you're kind of applying to 2 different things at the same time. So in total, I applied to like 140 programs in total. So 50 applications were for the prelim and transitional year, and the remaining 90 were for radiology. And prelim transitional year programs can be deceptively hard to get interviews at as an IMG. Know that, and also try to network with those programs that you're planning to apply to for prelim. Helpful resources. There's one resource that I want you to check out. It's the radiology room that has most of what you need for just general radiology as a prospective applicant for the US radiology match. Please check it out. Twitter is a very helpful space for these two and people just connecting with people and asking questions. So that's about it. I will leave room for questions if there's anything that I've not talked about. Thanks, everyone.
Thank you so much, Subomi, for very detailed and clear session. One question I actually had in mind, and it's just because I am in the UK and know more about the UK pathway. So there's like a self-assessment or like a portfolio that is kind of very defined, and you know like what each achievement is going to get you in terms of points compared to other candidates. In the US, is it all a big picture, or is there like, oh, I mean, if I have 2 publications, is that fair enough? Or do I need to have 5 publications to get to a certain threshold? Like, is there something like that when you're trying to apply?
Yeah, unfortunately, there is no like score sheet that when going into an application, you can't really say, oh, I score 70 out of 100 possible points for how competitive my application is. However, there are metrics. So the step score is one of the so that's why the step scores are so important, because people know that there's no score sheet, and that's the only numerical comparison that you can apply across all applicants. So having an above average step score is pretty important. As far as publications go, the NRMP also releases data on the mean number of publications for people who successfully match into so and so. It's only a guide. I've seen people match with 0 publications at good radiology programs, because all of these things is it's a holistic review. So a program director can't expect an IMG who just graduated from med school last year to have the same number of publications as an IMG who graduated 10 years ago. And one trap that I almost got into, and a friend had to call me out and say, hey, this person that you are looking at like as a quick applicant has been out of med school for 10 years. So they have publications. They will have more than you. So the programs actually, they have a score sheet too. Some do, some don't. And when they interview, they also some have a standardized scoring system, but by and large, it's like a holistic review of the applicant. Yeah.
Okay. I think Collins have put one of the viewers have put like a link for the radiology room on the chat box. Thank you for that. I'm just going through the chat, but I don't think I can see other questions there. Does anyone have any specific question to ask? I think it was really like quite clear. And if you have any queries, you can just let us know actually. So, but on the average, I would ask this one now. I'm an IMG. I'm just graduating from med school. To be competitive enough for radiology, um, like what time period do you think I'm looking at realistically as an IMG just finishing?
Mm. Well, so that's a good question. I don't have a straight answer to that question. On one hand, when you apply, the earlier you apply, the more com- early application. How do I put it? Years of graduation is one thing that programs look at. So they want younger, fresher people. That helps. But they also look at publications. So if you're coming with years of graduation super early, then you're also sacrificing other things that you could have built on, like building a network, building research. Some programs would actually say that they will not interview candidates with less than 2 years of dedicated research or clinical experience in the US.
Mm.
That's for radiology. So some programs will say that. So you're sacrificing on those programs. For fields like internal medicine, where you menstruate on hands-on, they really, really value younger IMGs. But I've found that radiology tends to value what you have than how young you are, because radiology is a very intellectual field. So the more experience you have, obviously, the better for the program. So I would say, a balance. So trying to get some research in, if you have none, it will be helpful. But I've also seen people, I know someone in particular who matched without research, but he didn't match the first time. And then he matched into a Prelim program in a really good hospital, and then
Mm.
was able to connect with the radiology people in that hospital, eventually matched there. And when he applied again, the programs that interviewed again, the second time were similar to the first time. So research is, for radiology, I would say research is pretty important. And the reason it's important, it's sad, but you're competing against US graduates who have known for a couple years, and so they were able to get mentors to get them on projects. So they have research. So as an IMG, you just have to have, right? So, um, but high step scores for sure. For recent graduates, what else? Letters from the field. So if you have a good step score and a very enthusiastic letter, like the person said that the sun shines on you and sets on you kind of letter, he's the best person in the world. Like people will want, especially if it's from someone that the program directors know, they've worked with that person. When you get that kind of letter, then you've bridged so many things. So letters are also really important. And sometimes the way to get that letter is having clinical experience with someone after medical school. So
Yeah.
it's all a balance.
So we have some questions on the chat box. Prince is asking, say, what's the difference between research item and research publication, as the US uses the term research item?
Yeah, that's a good question. So research item, and by research item, I'm not sure if you're referring to research experience. So there's research experience, and then there's research publication. Research experience is like, say you were a research assistant for someone, that counts as a research item. So research experiences and publications are both research items, but the research experience is basically what it is, an experience. And then a publication is either a peer-reviewed journal publication or a conference proceeding or a conference presentation or poster, oral presentation or poster. Those are research publications.
Yeah.
And publications can also include um, those that are still under peer review. So if you've submitted them for peer review, but they're still not yet published, they still count.
Okay.
Also, a question on
Yeah.
electives and clinical shadowing.
Yeah. Yeah.
So electives and clinical shadowing. So one kind of overlaps the other. So shadowing is a thing. Electives are a thing. So electives are basically what you elect to do in medical school as like extra training. So clinical electives, I'm not sure what medical school you are from, but most medical schools will offer you a period where you can do anything you want. That's the highest yield thing that you can do for US clinical experience. Getting to do US clinical experience when you're still a medical student, that is more impactful than after, because it's difficult to get hands-on clinical experience after, because now you have a license. Your liability is no longer on your medical school when you were a medical student. If that makes sense.
Yeah.
Clinical shadowing. So shadowing is also called observership. So you're shadowing, you're not really doing anything. It also counts. In radiology, for the most part, you're shadowing, even if they say it's hands-on, they're not going to ask you to type reports because you probably don't know how to use the PACS system. And you're probably going to write really terrible reports anyway. So no one is going to ask you to do that. What they will ask you to do as a someone who's shadowing, who's applying, is to sit with a radiologist and to ask questions and answer. So if you ever get experience to shadow, don't be shy. Ask the dumbest questions, because that's what shows that you're curious. And no one expects you to know anything when you're shadowing in radiology, because it's a very niche field. So shadowing helps for sure. If you are coming to the US for any other thing, so one thing I did was, because I'm in a research fellowship, it doesn't allow for clinical activity, but it does allow for shadowing. So I did a lot of informal shadowing with the radiologist here, and I put that in my ARAS application as I shadowed. It wasn't structured. I did it for so and so hours every week for so and so period of time. Yeah.
Yeah. The Collins, that's the question. Says, will a letter of recommendation from a relative be considered by programs? Also, can he get a letter of recommendation from, say, a radiology nurse?
Yes. Thanks for the question, Collins. That's a good question. I would not recommend getting a letter from a relative for obvious reasons. A relative will write whatever helps you as their relative. So the letter is not will not be viewed as objective by the admissions committee. So if you can, what a relative can do for you is advocate. So always separate. So who are my letter writers? Who are my advocates? Advocates are people that can talk to the program. Hey, I know this guy. He's pretty cool. Look at his application. A letter writer has to say how they know you, what you've done together, and what is the basis for their recommendation. So unless that relative has worked with you, and it could be if it's an extended relative, you don't share the same surname, I would say, as long as you worked with them and they assessed you clinically, fine. But if you share the same surname, even if you're not related, I would probably not get a letter from someone that shares the same surname with me, because I'm just thinking about it from the admissions committee perspective. They're probably not going to look at that letter very
Strongly.
favorably. Radiologist letter, I would say, don't think that I don't think you I don't think that is possible, because whoever writes your letter has to be board certified. I think they have to be board certified. I don't know if a nurse can be board certified in radiology. So a nurse can be your advocate. A nurse may have friends in a program that she's worked with in the past. So use the nurse as an advocate, but I don't think she should be your letterer, because it's I mean, as a program admissions committee member, I will feel a little I wouldn't I wonder why a nurse is writing for you as a physician. So I probably will not go that route. Yeah.
Wait, is there a limit to the letter of recommendation in terms of the number? I'm not sure I got that part.
Yeah, so that's a great question. So you can get 20 letters of recommendation on ERAS, but you can only submit 4 per program. So each program has You can mix up your letters, however. You can tell 20 people to submit letters for you on ERAS, but you only end up using 5 of them.
Okay.
So a safe thing to do might be have each program only requires, I think each program requires a minimum of 3, if I'm not mistaken, but a maximum of 4. So yes, you can't do more than 4. And that might change this year. And then you can mix up your letters however you want. Yes, you can definitely
Okay.
mix up your programs, your letters rather.
Okay. One last one, and this one may be unfair, but do you, no, it's not unfair. So for someone that's trained in that country and now a consultant, are there alternate pathways in working in the US, or it must be doing your USMLE and training in the US? In
That
terms
is a great question.
Yeah.
That's a great question. And one thing I made a note to mention, eventually did not, was that I wasn't really talking about the alternate pathway because I didn't use that pathway. I know of it. So if you are licensed to practice radiologist somewhere else, there is an alternate pathway that involves you doing, I think, 4 fellowships. So when you do 4 fellowships at US accredited US institutions, then you can be board certified. You can be a board certified radiologist in the US. Yes, so that is possible.
But like, will you just be able to do the fellowships without having like background USMLE steps though?
I think that
That's one.
I think you need the USMLE steps written. I think you do need the USMLE steps written, and I think you also need to be ECFMB certified. But I think we should, might want to confirm, cross-check that. Yeah.
Okay. Thank you very much for the session once again. For those attending, I've provided the feedback form in the chat box. Please, this feedback is very important, not just for us, but also for our guests. When the program ends, anyone that attended will also get an email asking to fill the feedback. And it is after you fill the feedback, you get like a certificate for this event. So please do fill the feedback. Just one other announcement more of. I know we did the session for the UK pathway. That was 2 weeks ago. Was it 2 weeks ago now or last week? My brain is even I think it was last week. So some attendees had asked about the ST3 pathway for the UK. We I told you guys I'll come back to you, like if we're able to find a way to arrange that. So the RIGAF that we talked about last week, as the Radiology Interest Group of Africa, they'll be doing an event this coming week on that, explaining that pathway. So for those that are interested, I'll put the link on the chat box here, but I'll also put it on the group page so that you can all register and attend the event. Subomi, I don't know if there's any last words you like to say before we officially close the event.
No, thank you for having me. Thank you so much. Nothing more. But feel free if you have any questions.
Yeah.
You can email or message on Twitter, or just put my email in the chat.
Okay. All right. Thank you so much.
Yeah. Yep. Okay.
Yeah, I think I can see it.